Good day. Welcome to your dermatology class of 2020. We hope that you would learn a lot or even just a little from us to guide you in your future practice. These are the following topics to be discussed for this semester. Our first topic will be basic dermatology. The skin is essential for life. It has different functions for our protection. First, it has a barrier function. It protects the body from mechanical damage like friction or impact. It is a poor conductor of heat. Thus, a barrier to heat injury tolerates only less than 40 degrees Celsius. Higher temperature may cause marked tissue destruction. It also protects us from bacteria, fungi, and virus. It protects us from chemicals, but excessive exposure to these chemicals may cause dermatitis and burns. Superficial layers protects us from the sun, especially the ultraviolet radiation and excessive sunburn. The skin also maintains fluid balance. It prevents the skin from drying out, it prevents absorption of excess water, and it excretes waste through our sweat. The skin regulates body temperature. Through evaporation of sweat, thus we cool down. And in cold weather, our subcutaneous tissue, blood vessel, and hair help us warm up. The skin also helps fight against microbial and allergic reaction. Another function is that it synthesizes vitamin D, it stores electrolytes, water, vitamins, and carbohydrates, and it also aids in wound healing. The skin also has a communication function. It gives us different sensations like pain, touch, cold, etc. It also makes us beautiful. That's why we do a lot of skincare routines and we spend a lot in makeups. It also shows our emotional state. Like if you are nervous, you're going to recite, you sometimes sweat. Or if you see your crush, you turn pink or reddish. Or if you see a ghost or you are scared, you turn pale. Our skin is very important, so we must always take care of it. This is the anatomy of the skin, the different layers, and its appendages. So we will just go to the basic. Name the 3 layers of the skin. So we have 3 layers. The epidermis is the outermost layer and is composed primarily of keratinocytes. Beneath it lies the dermis, which is composed primarily of collagen but also contains adnexal structures. Below the dermis lies the subcutis or the hypodermis, which consists of adipose tissue, blood vessels, and nerves. There are 4 layers in the epidermis. The innermost layer is the basal layer. It is composed of columnar or cuboidal cells in direct contact with the basement membrane. It is the structure that separates the epidermis from the dermis. Occasional mitosis usually happens in this layer. The stratum spinosum has a high concentration of desmosomes and keratin filaments, giving a spiny characteristic to the cell. Above it is the stratum granulosum, where keratohyalin granules are formed. And the outermost layer is the cornified layer, where the keratinocytes abruptly lose all of their organelles and nuclei. 2 other types of cells normally occur in the epidermis. So aside from the keratinocyte, we also have the melanocyte, Langerhans cell, and Merkel cell. Keratinocyte makes up 90% of the cell in the epidermis. It has both a structural and immune function. Melanocyte is the most common dendritic cell situated in the basal layer. There are approximately 36 keratinocytes for each melanocyte. The cell function is to synthesize and secrete melanin-containing organelles called melanosomes. Apocupation is the process by which melanocytes transfer melanosomes to keratinocytes. Problems in melanocyte and melanin pigment result in skin disorders like vitiligo, in which there is destruction of melanocytes, albinism, in which there is little or no melanin pigment. Collection of melanocytes can be seen in the common mole or the nevus, and uncontrolled growth of melanocytes can become melanoma. Remember that racial differences in skin color are not caused by differences in the number of melanocytes. It is the number, size, and distribution of the melanosome or pigment granules within the keratinocytes that determine the skin color. There are two types of melanin. More common is the eumelanin, which gives the brown or black color, and pheomelanin usually gives a red or yellow color of the hair. Next cell is the Langerhans cell. The Langerhans cell is an antigen-presenting cell that has a very important immune surveillance function. It is primarily distributed in the spinous layer. Small number of Merkel cells are found in the epidermis. The function is not fully established, but they are frequently in contact with nerve fibrils. Next, we go to the dermis. The dermis is 1 to 2 mm in thickness. It consists of collagen, elastic fiber, and proteoglycans. Functions of the dermis include temperature regulation through control of cutaneous blood flow and sweating, mechanical protection through collagen and hyaluronic acid, and innervation of the skin mostly occurs in the dermis and is responsible for cutaneous sensation. The dermis is organized in two distinct areas: the superficial papillary dermis, which is a relatively thin zone beneath the epidermis. It is composed mainly of collagen and is highly vascularized. The deeper zone is the reticular dermis, which comprises the bulk of the dermis. It is less vascular than the papillary dermis and demonstrates thick, well-organized collagen bundles. The main cell in the dermis is the fibroblast. The fibroblast produces the collagen for resiliency. Elastic fibers, or elastin, are also found in the dermis and gives elasticity to the skin. Proteoglycans is there to maintain water within the dermis. Diseases that affect the dermis are often seen in connective tissue diseases. This is a term generally used to refer to clinically heterogeneous group of autoimmune diseases. This includes lupus erythematosus, scleroderma, and dermatomyositis. So after the dermis, we now go to the hair follicle. Hair follicle are epidermal cells with tube-like depression that extends into the dermis. Hair color depends on the degree of melanization. Black hair usually has large melanosomes. White people or light-colored hair has smaller and aggregated melanosomes. Red hair has spherical melanosomes. Graying of hair is due to decrease in melanocyte causing decrease in melanosome. If your hair is curly or straight depends on the cell shape, and the hair density depends on the secondary hair follicle. Hair follicle undergoes lifelong cyclic transformation into 3 phases. Anagen phase is said to be the growing phase. Rapidly proliferating epithelial cells are seen on this stage, and this is sensitive to stress, drugs, immunologic, and physical injury. 80 to 90% of scalp hair is usually in the anagen stage, and it stays in the human scalp for 3 to 5 years. The transitory phase is known as the catagen phase, and the resting phase is the telogen phase, which averages 3 to 5 months. Have you experienced excessive shedding of hair? So this is because large number of the otherwise normal telogen hairs are present, and it stays for a prolonged period of time, more than 3 to 5 months. And this is often due sometimes to stress, sometimes to the immune status of the patient, sometimes nutritional because of dieting, and sometimes because of sickness. Now we go to the dermal appendages. The eccrine gland is widespread in the skin. It is found in the deeper dermis or hypodermis. It is a type of merocrine gland, and the main function is thermal regulation. Apocrine glands secrete odorless oily fluid in periodic spurts until it reaches the skin surface where it is altered by bacteria, which makes it odoriferous. It is found in the axilla, areola, nipple, and the anogenital region. The sebaceous gland are anatomically and functionally related to the hair follicle. It is a holocrine gland, and the function is that it secretes sebum that lubricates the skin and protects it from friction. It is abundant in the face and the scalp, but absent on the palms and on the soles. The subcutaneous layer, or the hypodermis, is arranged into distinct fat lobules, which are divided by fibrous septa composed primarily of collagen. Blood vessels, nerves, and lymphatics are also found in the fibrous septa. The role of the subcutis is mainly for caloric reserve, as heat insulator and shock absorber. Next, we go to nails. Nails protect the terminal phalanx and fingertip from traumatic impact. They allow us to perform tasks that require manual dexterity. They relieve us when we are itchy. And for many individuals, they represent an extension of their aesthetic beauty through manicures, pedicures, and nail art. Why are the nails important? Because they are commonly affected by numerous internal and external factors that may help us find clues to certain systemic disorders. Koilonychia is primarily recognized as a manifestation of chronic iron deficiency. Nail pitting may be due to psoriasis, eczema, or joint inflammation. Buse lines are indentations that run across the nails that appear when the growth at the area under the cuticle is interrupted by injury or severe illness. Nail clubbing may be associated with heart or lung disease. Thickening and discoloration of the nail may be due to infections. Leukonychia or white spots on the nail can occur due to injury to the nail bed because of frequent manicures or pedicures that may damage the nail bed. Remember that the fingernails grow at a rate of 0.1 millimeter per day and can be replaced by 4 to 6 months, and the toenails can be replaced by 12 to 18 months. So now we are finished with the anatomy and the basic dermatology. We now go to history and physical examination. Remember, diagnosis in dermatology is most frequently based on objective physical findings. The advantage in dermatology is that you can see and feel what you need to examine, and a thorough physical examination is paramount in diagnosing a disease. Most skin diseases produce or present with lesions with more or less distinct characteristics. The original lesion is known as the primary lesion. So when it's original, these lesions are not altered by trauma, manipulation, or natural regression over time. So these are the primary lesions that we are going to discuss. Macule is a mere discoloration of the skin and is flat. It is less than 1 centimeter in size. If it is greater than 1 centimeter, it is now known as a patch. The color of the patch or the macule depends on where the pathology lies. Brown discoloration is usually pigmentation in the epidermis. Bluish discoloration is usually pigmentation in the dermis. And red discoloration can be a collection of red blood cells within the blood vessels or inflammatory infiltrates within the immediate surrounding blood vessels. So we have different types of macules and patches. Tan-colored macules and patches, called café au lait spots, are seen in neurofibromatosis. Whitish patches seen in vitiligo. Special macules, which are pinpoint to pinhead-size bright red macules, are called petechia. Slightly bigger is known as purpura, and very big and sometimes purplish in color is called ecchymosis. Green or blue macule or patch is commonly seen in newborn, and this is called the Mongolian spot. Morbilliform eruption are often seen in viral exanthems like rubella or rubeola. Morbilliform often represents lesions forming macules and papules. Now we go to a papule. A papule is a raised lesion with no visible fluid and is less than 1 centimeter. It can be acuminated, rounded, conical, flat top, or umbilicated. In the picture, we see a flat top papule, and this is often seen in lichen planus. Molluscum contagiosum, which is a viral infection in children, often shows umbilicated papules. Brownish papules are often seen in melanocytic nevus, and yellowish papules are seen in xanthoma. Raised lesion more than 1 centimeter and usually flat top may be centrally depressed is called a plaque. A nodule is also a raised lesion, but the important feature is that these lesions are deep. The pathology centered in the dermis are the subcutaneous fat and are larger than 1 centimeter. In the picture, we can see examples of nodule in basal cell carcinoma and neurofibromatosis. A tumor is a soft or firm, freely movable or fixed mass in various sizes or shapes. It is generally greater than 2 cm in diameter, and their consistency depends on the constituent of the lesion. Tumor is usually used to denote neoplasia. Next is the wheal. The wheal is described as erythematous, edematous, and evanescent. A prototypic lesion of wheal is seen in urticaria, or what we call hives. Next is a vesicle. It is a fluid-filled lesion less than 1 centimeter. They may be pale or yellowish from serous exudate or red if mixed with blood. It may be subclassified depending where the split occurs. In the picture, you can see impetigo. The split occurs right beneath the stratum corneum, naming this the subcorneal intraepidermal vesicle. The split can occur mid-epidermis or right over the basal layer. The clinical picture shows herpes zoster or shingles. The split can also occur right beneath the epidermis, and this is often seen in bullous disorders like pemphigus vulgaris. If the fluid-filled lesion is more than 1 centimeter, they only differ from the vesicle on its size. The fluid content of a vesicle or a bullae may be useful in cytologically confirming the diagnosis of the disease. A pustule is a pus-filled lesion, usually of necrotic inflammatory cells. But it doesn't necessarily mean that there is an infectious process, since there is such a thing as sterile pustule, often seen in pustular psoriasis. Next, we go to a cyst. A cyst is an encapsulated lesion with liquid or semi-solid content. Examples are milia or milium, known as the keratin cyst, steatocystoma multiplex, which is a sebum-containing cyst, hydrocystoma, which is the cyst of the sweat ducts, and epidermal inclusion cyst, which is the implantation of the epidermal cells in the dermis. Next is the secondary lesion. Secondary lesion is a result of regression, trauma, or other extraneous factors towards your primary lesion. For example, the primary lesion is irritant dermatitis secondary to the frequent use of alcohol on your hands. So it often presents as macular erythema or redness. But with resolution, secondary lesion will occur, such as scaling and increased pigmentation. So these are the secondary lesions that we are going to discuss. First is the scale. The scale is a dry or greasy laminated masses of keratin. Remember, our body normally sheds imperceptible fragments of stratum corneum every day. When formation of epidermal cells is rapid or where there is disturbance in normal keratinization, then we see pathologic exfoliation characterized by your scales. In the clinical picture, this is often seen in seborrheic dermatitis or what we commonly know as balakubak. Some scales vary in size. Some are fine, delicate, and briny like in pityriasis or tinea versicolor. Others are coarser or plate-like, often seen in ichthyosis. Some are stratified or silvery in color, seen in psoriasis, and some presents as large sheets of desquamated epidermis, often seen in TEN and staphylococcal scalded skin syndrome. Crust. This is composed of keratin, dried serum, leukocytes, bacteria, and debris. In the clinical picture, this shows the bacterial infection in pitigo, where you can note dry golden yellow, soft friable crusting. Next is the fissure. The fissure is a linear cleft through the epidermis or into the dermis. They occur mostly when the skin is inelastic from inflammation and severe dryness. This usually produces pain when the lesion deepens or opens or form new ones. This is seen in chronic skin conditions like allergic dermatitis and psoriasis. Erosion is a loss of part of the epidermis, but the basal layer is still intact. Since it is intact, new skin will arise and no scarring will occur. But if there is loss of all of the epidermis, with or without part of the dermis, this is termed as an ulcer. Loss of the basal layer of the epidermis means the connective tissue in the dermis will try to fill up the defect, giving you a scar. Scars are composed of new connective tissues that replace lost substance in the dermis or deeper parts as a result of injury or the disease. Scars could be hypertrophic, keloidal, or atrophic. In the left picture, you can see the hypertrophic scar, the scar that doesn't go beyond the margins of the original wound. There may be slight stretching of the skin expanding the wound. Keloid is an overabundance of connective tissue. As seen in the picture, the ear piercing of the earlobe which doesn't produce a hole and instead you have a protruding mass. Excoriations are punctate or linear lesions involving the epidermis, sometimes reaching the papillary dermis. This is often caused by scratching with fingernails in effort to relieve itching, and this is often seen in atopic dermatitis or chronic eczema. Abrasion is a term used for mechanical trauma or constant friction. So next, we go to the physical examination. We examine our patients in a well-lit room, and the optimal light is usually sunlight. We also use some gadgets like Woods light to determine certain diagnoses like pigmentary disorders, and infections like fungal and bacterial infections. We sometimes use magnifying lens to see very small skin lesions. We often touch the patient or palpate to elicit some signs, and we often ask the patient to undress to see the distribution, the grouping, and the configuration of the skin disorders. We also note in the history the evolution and the involution of the skin disease. So we're going to discuss 4 signs in dermatology. Barrier sign is seen in urticaria pigmentosa. Typically, patients with urticaria pigmentosa presents with just brownish macules or patches. So you try to rub these macules, and when the lesions urticate or becomes raised and then becomes reddish, you can think of urticaria pigmentosa as a diagnosis. Fitzpatrick sign or dimple sign is seen in dermatofibroma. When you try to pinch the brownish papule and it produces depression, this is called the Fitzpatrick sign. Removing of the scale that produces punctate bleeding is often seen in psoriasis, and this is termed as Auspitz sign in psoriasis. Nikolsky sign seen in pemphigus vulgaris causes dislodgement of the superficial epidermis when you do a lateral sliding pressure. The Asbo-Hansen sign is another sign in pemphigus in which you put pressure over the blister, which causes the fluid to go to the normal part of the skin. Remember that we must note the distribution, configuration, grouping, the evolution and the involution, the color, consistency, and the sensation of the skin to note the diagnosis. These are the following configurations and groupings. Example of which is the herpes zoster, which shows a dermatomal or zosteriform distribution. Target or iris lesions are often seen in erythema multiforme. Linear configuration is seen in epidermal nevus. To stress the importance of undressing to do physical examination, we can see the Christmas tree pattern, in which rashes follows the lines of cleavage, often seen in pityriasis rosea. This is a form of epidermal nevi that follows the Blaschko's lines. Blaschko's lines, or the lines of Blaschko's, are thought to represent pathways of epidermal cell migration and proliferation during the development of the fetus. Several intersecting portions of circle, or known as the polycyclic configuration, are seen in erythema annularis centrifugum. When one lesion succeeds one another in a series of crops, this is known as the evolution of the lesion. Example is varicella or chickenpox, which shows lesions in various stages of evolution. For example, it starts as a papule, then becomes an intact vesicle, then the vesicle will erupt, causing necrotic centers. When lesions disappear, this is known as the involution. It can have ulcers, eschars, and scars. An example is seen in pityriasis lichenoides acuta. Thank you for listening.